Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Sage Therapeutics and Biogen, Inc.
Hello, I'm Dr. Camille Hoffman. I'm a professor of maternal fetal medicine at the University of Colorado in the departments of obstetrics and gynecology and psychiatry. Welcome to this program titled Revolutionizing Postpartum Depression Care, Expert Insights and Patient Perspectives on the Diagnostic Journey and Treatment Approaches. Joining me today are Dr. St. Jean and Dr. Grace Lim. Dr. St. Jean, would you please introduce yourself?
Yes, so happy to be here today. I am an associate professor of OBGYN at New York Medical College, which is my alma mater, and I'm also the co-chair of the Maternal Mortality Review Board for the New York City Department of Health.
Thank you. And Dr. Lim, also please introduce yourself.
Hi, my name is Grace Lim, and I'm a professor of anesthesiology and perioperative medicine at the University of Pittsburgh School of Medicine in Pittsburgh, Pennsylvania.
We're also joined by Jessica Garcia Wood, a patient advocate. Jessica, would you please introduce yourself?
Hi, I'm Jessica Garcia Wood, and I was diagnosed with postpartum depression and anxiety about 3 months after having my son, who is now 3 years old. We are in a much better place now, and I'm really happy to be here.
Thank you for joining us, and welcome everyone. In this conversation, my fellow panelists and I will be providing the perspective of healthcare providers and the patient on the diagnosis and management of postpartum depression. Many of you are already aware of how common postpartum depression is. With the conservative estimate of 1 in 8 mothers developing postpartum depression, how do we go about finding it, making the diagnosis, so that our patients can be treated? Well, in the 2023 ACOG Clinical Practice Guidelines, the recommendation was put forth that everyone receiving well woman, pre-pregnancy, prenatal, and postpartum care should be screened for depression and anxiety using standard validated instruments. Another recommendation was that screening for perinatal depression and anxiety should occur at the initial prenatal visit, later during pregnancy, and at any postpartum visits. These screening recommendations were made because we know that about a third of depression begins prior to pregnancy, another approximately third will emerge during pregnancy, and the final third will be diagnosed during the postpartum period. Dr. Lim, do you have any other comments about other organizations that have provided guidelines, including Postpartum Support International?
There are other organizations that have provided guidelines to screen peripartum people who may have mental health disorders. For example, Postpartum Support International, or PSI, recommends universal screening for maternal mental health disorders during not only the prenatal period, but also in postpartum visits with obstetricians. And the recommended timing of these screenings include the first prenatal visit, at least once during the second trimester, at least once during the third trimester, at the 6-week postpartum obstetrical visit, or at the very first postpartum visit, because not all of them will fall at 6 weeks, and continued and ongoing screening at 6 months or at 12 months in obstetric or in primary care settings. You'll notice that these are repeated screenings because, as Dr. Hoffman has pointed out, maternal mental health disorders can become obvious not only in the postpartum period, but anytime during the pregnancy and into the first year after delivery. The PSI also recommends screening in the pediatric setting at these intervals. And specifically, they recommend 3 months, 9 months, and 12 months for maternal mental health screening to occur during the pediatric well child visit with the pediatrician. And this is important to note because often undiagnosed or unrecognized mental health disorders, such as anxiety or depression in the mother, um, will manifest as caretaking for the child, meaning taking the kid to the visits that are necessary, but skipping out on their own care. And so, this is a holistic approach that PSI has recommended and is intended essentially to try to capture a diagnosis or a positive screen in any of the care settings that may touch the maternal visits. Other organizations that have provided guidelines include the American Academy of Pediatrics. They recommend that pediatricians routinely screen mothers for postpartum depression at the well child visits. And specifically, they say at 1 month, at 2 months, at 4 months, and at 6 months, the screenings should occur. Similarly, in 2018, there was a position statement that was put out by the American Psychiatric Association, or the APA. They recommend a total of 6 screens throughout the perinatal period, and that includes 2 screenings during pregnancy. The recommended timing of the screenings that are conducted by the primary obstetrician should be at least twice during the pregnancy and at least once in the postpartum period. And further, they recommend screening in the pediatric setting at 1 month, at 2 months, and at the 4 month well child visit.
Which validated tools or measures can be used for screening and by whom? Dr. St. John, would you please tell us about screening that's done in your practice?
Thank you. Yes, there are various questionnaires that can be utilized by different healthcare providers, not only OBGYNs, but also midwives, nurse practitioners, and those that see all of our patients during their prenatal course and during their postpartum course. And so when we look at these, and this table really kind of explores the different types of questionnaires, we can look at those that look at depression, anxiety, and also bipolar disorder. The tools that we use, one of which is called the EPDS. And this again is utilized to consider items where we explore patients not only for depression, but also for suicidality. And again, there is a sensitivity and a specificity that is used to really explore if our patients do have postpartum depression and whether it's mild, moderate, or severe. And when we think about the scoring of this questionnaire, a positive screen is a score of greater than 10. And then again, postpartum depression, we can utilize EPDS or the PHQ-9. Now, when we want to really delve into anxiety, which is again another one of the PMADs that we explore and that our patients can have after delivery or after having a baby, we look at the GAD-7 and we also look at the EPDS. We have a lot of tools in our arsenal that we can really explore depression and anxiety, which impact a lot of our pregnant women and pregnant people. Utilizing all of these questionnaires can help us really identify and assess our patients for depression, anxiety, bipolar disorder. And again, we know that when someone rates positive, then we can initiate other testing, including the obsessive compulsory inventory, but also using the Columbia Suicide Severity Rating Scale. Who should be screening? And so I really touched on this because it's not only our obstetricians. We have to understand that obstetric providers come in all different flavors, right? So it could be our OBGYNs, but it could be our midwives. It could be our family practice partners. It could be our pediatricians. It could be our nurses. And then there's also mental health professionals, our community health workers as well, our lactation consultants, our doulas, and our social workers. There are many different providers that look at our patients from all different aspects that can do a proper assessment and screening for postpartum depression.
Really important points. A really strong front line of people who can be involved in this and improving our screening and diagnosis. Jessica, I'd love for you to chime in with your own experience with postpartum depression. Who screened you? And who helped you receive the treatments that helped you get well?
Yeah, so I had my 6 week follow up, and I was given the EPDS. And I remember not even being able to finish it because I saw what was happening right in front of me. And I remember looking at the nurse practitioner that was taking care of me. And I told her that something was wrong and that I knew something was wrong and I needed help. She actually ended up at the end of that appointment, walked me over to the psychiatry office, which was in the same building, just to get me introduced to the staff there. They actually had a really good handoff process, which I really appreciate because in that same day, I was able to get to see a psychologist and a psychiatrist, and that got the ball rolling with my treatment.
Thank you so much for sharing that. It sounds like in your setting, they had integrated behavioral health care within the prenatal or perinatal clinic. And that is one of the ideal situations to improve access and the number of people who can look after you. Shall we dive a little into the clinical characteristics of PPD? Dr. St. Jean, would you talk a little bit about diagnosis?
Yeah, so, what is important, and I think what also Jessica exhibits is that, again, it has to be a multi layered approach. And before we can even get to that approach, let's just make sure that we are all grounded in the DSM 5 definition. So, postpartum depression is a major depressive episode with onset during pregnancy or within 4 weeks postpartum, and it commonly extends up to 12 months of postpartum in clinical settings. These are the core symptoms, okay? So it's depressed mood, it's tearfulness. And again, I have to really commend Jessica for her bravery, for recognizing that there was something wrong. And she really kind of did not allow any shame or stigma for her to really seek out care, but also to even talk with her provider. There's anhedonia, which is the loss of interest or pleasure, and fatigue or loss of energy. One of the other symptoms is feeling of worthlessness or guilt. There also could be difficulty concentrating, sleep or appetite disturbance, psychomotor agitation or retardation, and also, and most importantly, thoughts of death or suicide. And remember, often this happens in that postpartum period where you are supposed to be enjoying the joys of motherhood, but you are experiencing these symptoms. And recognition and identification of these symptoms is so important for you to access and receive the care that you so rightly deserve. And again, there are more additional signs in postpartum contexts. There's the feeling of being an inadequate mother. Also, there is sleep deprivation that happens, but also as a mother, you may feel that you're inadequate. There's anxiety focused on infant care or safety. And so this doesn't allow you to enjoy that bond or even have that bond, right? Because there's so much anxiety surrounding the care of your infant or even their safety. One of the signs that we see with postpartum depression is there is a withdrawal from the infant. And also, there could be an avoidance behavior or suicide.
Really important points. Thank you for making them. What would be the potential comorbidities that obstetric care clinicians should be aware of? Dr. Lim, would you please speak a little bit about that?
Of course. There are a few comorbidities or basically other conditions that can exist together with postpartum or perinatal depression. Common ones that we see on the mental health side include anxiety disorders, which is extremely very common. Even outside of the context of pregnancy, anxiety and depression can coexist and often is on a spectrum where anxiety gets more depression and vice versa. And so often you may see or suspect diagnoses of generalized anxiety disorder or even panic disorder or obsessive compulsive disorder. There are other conditions as well, such as post traumatic stress disorder. This can actually be an important one in the setting of obstetrics and perinatal patients because there are conditions or situations where the birth situation may itself be um, perceived by the parent, the mother, to be non routine and processed as traumatic. So, some situation in which these may come up include preterm deliveries or surprise deliveries that were unplanned, uh, babies who may need unexpected or unplanned neonatal intensive care unit, hospitalization, or any other perinatal complication, whether or not is defined as a complication by the obstetric provider. This is important to recognize that these can be difficult to process for patients and can potentially result in acute stress disorder, potentially then leading to PTSD, which is a comorbid condition with postpartum depression. And other situations other comorbidities you may see together with depression include substance use disorders and also bipolar disorder, which is why that is part of the screening that is recommended by ACOG. Um, Beyond the mental health conditions or psychiatric comorbidities, there are also physical or medical comorbidities that may also exist together with depression. These often coexist with depression, and depression can make these conditions worse, and vice versa. These conditions can also make the symptoms of depression worse as well.
And we often hear that there are barriers to diagnosis, as well as access to treatment and access to continued care. Jessica, what barriers did you experience in your diagnosis?
So I think that's got two layers to it. I will start by saying that on the clinical side, I don't feel that I had any barriers. I was very fortunate. I was actually in the military when all of this was happening, and I received wonderful care. I had wonderful providers, and my leadership team really supported me through this. On top of having a wonderful husband who was going through it right there with me, but was as supportive as anyone can be. I will say that the other layer of barriers is definitely as we were going through that list that Dr. Zane Sean was going through, it took me back to a place where I was remembering all of those ugly things that I felt when I was initially going through that. And it started when I was actually pregnant. I knew something was wrong. That I remember my mother-in-law asking me, "Oh, don't you feel that bond with your baby in your belly?" And I didn't know how to answer that because in all honesty, I knew that I had to protect this baby. This baby was my responsibility and this baby would be loved, but I just had a really hard time connecting with the baby. For whatever reason, my brain was saying, "You don't really even know who this is." So when that started, I felt that shame, that guilt, and I didn't voice it to anybody except for my husband, who again was super supportive. But I will say that that was a huge barrier in me speaking up because I think knowing what I know now, I would encourage anybody who has those feelings to talk to their providers about it because I think that I could have had a different outcome, a better outcome.
Thank you so much for sharing that experience, Jessica. It's all too common, and you highlight a number of important points. Would you also speak about the importance of your obstetric care team being a bridge to other mental health providers? I know you mentioned that your experience was when you were in the military, which is also a really important group, and maybe more vulnerable group for mental health conditions. But how did that weigh into your getting well?
So I think that's actually a really important question because when you are in the military, you have healthcare. And I was actually working at a military hospital, which meant that on that base, we had all the resources that we pretty much needed. I didn't have to worry about referrals and insurance. I had the luxury of just being walked right over to the mental health clinic where I met with a psychiatrist and psychologist. I know that that is not the case for a lot of people. there is that break in care for a lot of people where you make that transition from, okay, you've spoken with your OB provider and we've established that something is wrong. What is the next step? Not everybody has that luxury of their provider basically holding their hand and walking them over to the next point of care. Again, that was a luxury that I had that, I mean, really shouldn't be a luxury. It should be the norm. So I do think that that is another barrier in care for a lot of new moms.
Yeah, agree. Dr. St. Jean, would you please speak with us about how we typically approach PPD management in obstetric care settings?
Absolutely. So, before I delve into kind of the different approaches to PPD management, I just really need to applaud Jessica for her honesty, her bravery, and I don't realize how much she sees how she is going to help so many other people. There are general principles to treatment. Number one, we need to individualize treatment plans. Everybody is different, right? And we want to base them on the severity, the preferences, and also their individual breastfeeding status, because that would really delve into what pharmacology that may be used if needed. Also, we have to include their lifestyle interventions. What is their community? What does that look like in terms of their mental health or behavioral specialists, their psychotherapy, their pharmacological approach? What is needed for that individual patient, right? How do we customize treatment plans? And then also, we want to think about a multidisciplinary care team, right? And what that looks like. And we want care coordination between their obstetrician, their psychiatrist, their pediatrician, their therapist, and any other healthcare professional that is involved in their care. We want to interface with everyone and again provide that customized approach that would be ideal for every individual. And again, when we think about the scoring, we went over the questionnaires, right? What are the tools in our arsenal that we use to identify those with postpartum depression? Well, then once we get those tools that of assessment that are performed by our patients, we then categorize it into mild, moderate, and severe in terms of the scores. And that helps us really determine individualized care, whether it is support, sleep, and diet and activity, whether it's psychotherapy, or whether it's all of those and customized care for our patients. We want to view everything from a patient centric approach because that allows us to, again, really factor in that patient's social determinants of health. So, again, whether it's their social support, their nuclear support, their community, whether it's the addition of a mental health therapist or behavioral specialist, or a psychiatrist or psychologist, or if that's in the inclusion of pharmacotherapy as well. And when we talk about lifestyle interventions, again, not everything is from our mental health perspective and our pharmacological perspective. We have to also talk about sleep, right? Because we know in that early postpartum period, there is a lot of sleep deprivation that's involved. So, how can we kind of organize, right? So that we prioritize sleep? Also, nutrition, right? Are you eating enough? Are you eating enough protein for your healing process in general, right? Are you getting enough caloric intake, right? Is there movement, physical activity? Are you moving around? Are you leaving the house? Are some of the symptoms that you're experiencing prohibiting you from moving around, right? Do you have that social support? Do you have that network? Do you have that community that is helping you throughout this challenge that's happening in that postpartum period? And then also introducing stress reduction techniques, right? And coping mechanisms. How can we help you organize so that, again, we can really address stress head on? So the providers with the patients really identifying what are those coping and techniques that we can utilize that can really, really help, mood elevation, but also address postpartum depression. So again, we go over what ACOG guidance gives us, right? And so one of the things that ACOG talks about is psychotherapy should be considered as the first line for mild to moderate depression in conjunction with pharmacotherapy, which is SSRIs. But also there's other different forms of therapy. There's cognitive behavioral therapy, there's interpersonal psychotherapy, there's peer support and support groups. One of the things I always try to tell my patients, you're not alone. This is something that many people, again, we talked about how common it is, 1 in 8, right? So many people are going through this. And so sometimes having that camaraderie with others is also quite helpful. And then also talking about mother infant interventions. In totality, these can be helpful to many people who are experiencing postpartum depression. So again, the treatment options, when we talk about pharmacotherapy, there's two kind of big groups that we utilize. We have zuranolone, which was approved in 2023. Again, the onset is very fast. It's an oral formulation. The duration of treatment is about 2 weeks. Now, we don't have enough data to really kind of safeguard breastfeeding with that usage, and it can be expensive. And there is a GABA A moderator um, mechanism, but again, it is best for acute severe postpartum depression and for those who have a SSRI intolerant. And again, if you have severe insomnia or agitation. And then we have our category of SSRIs and SNRIs. And this is for extensive use. The onset is a bit slower, so about 2 to 6 weeks as opposed to, days of onset. It is again an oral formulation, and the treatment duration is ongoing. It is safe in breastfeeding. It is inexpensive and widely available. And we know that the mechanism is different. However, there it is best for long-term mood stability. So we do have different types of pharmacological treatments that we can utilize. And we want to, again, individualize treatment plans so that we are being very specific for that patient and their needs.
So many important points, Dr. St. John. Thank you. Dr. Lim, would you please speak a little bit about barriers to treatment at different levels, starting with the patient level?
Yes, there are existing patient level barriers to treatment. We've discussed a little bit a few of these, the stigma and shame that is often associated with a mental health condition, especially among new mothers. Fear of public or child protective services involvement can be a reason why many women may avoid seeking next steps or seeking help. The normalization of symptoms is one that I think is felt by several or many. For example, all new moms feel tired and overwhelmed. Um, and some of these conditions can be tricky, as previously mentioned, but also the constellation of the symptoms together can indeed indicate a diagnosis that requires a therapy and follow up. There's also a lack of awareness of postpartum depression as a legitimate medical condition, just like diabetes or anemia or hypertension, that can be treated. And because of that, these conditions can go untreated for a long time. There's concerns about medication safety while breastfeeding, despite some evidence that to suggest that many of these therapies are safe and effective, including during lactation. And there is also potentially limited time or childcare to attend these therapy sessions. That is a structural barrier as well. Socially and culturally, a few barriers may include if there is low health literacy or a language difference between patients and providers. This can hamper effective communication about a diagnosis and appropriate treatments. There may also be cultural beliefs that discourage a recognition of mental health care or that view it as a possible weakness, and that may color an individual's decision to recognize or seek treatment or help. There is also a mistrust of healthcare systems that does exist among marginalized populations, and that can act as a limiter or a barrier to seeking the help that may be necessary to get them better. And then finally, there's also a pressure to be present or to present also publicly, outwardly as a good mother. And this image does not necessarily coincide with the feelings that are inherent in a mental health condition. And this can create a social barrier. Along with the previous mentioned barriers are some healthcare system barriers and provider related barriers and clinical challenges. On the health system side, there are insufficient perinatal mental health providers to meet the demands, and this can create a major bottleneck to getting positively screening patients or people who need help to get timely help. And that has created some long wait times for psychiatric services. And there have been good discussions about what types or severity of symptoms really do need to rise to the level of attention of psychiatric care versus what could be handled in a different model of care that just hasn't been widely spread. But on the healthcare system side as well, there are insurance coverage issues that sometimes exist for psychotherapy and psychiatric care. They are non-uniform for some payers, and this can create some anxieties about whether the help that the patient may need will then create a different stressor on the payers on the payment side. And there's also a lack of integrated behavioral health services in many women's health or OBGYN settings, which creates, once again, those barriers to access. On the provider level side, we've previously mentioned mental health training, diagnosis, and referral pathways are currently um, felt to be inadequate in some settings, and that can create a sense of limitation on the provider side.
And Jessica, I'd love your perspective. What barriers did you experience in your PPD management, and how was your treatment implemented?
As far as actual barriers, the cultural was big. My mom, who was born in Mexico, I'm a first generation American, really had no understanding of why I needed medication. That was a really tough conversation. Although she was very supportive, I could tell that disconnect was there of, wait, this is something that's so natural to being a woman. Why are you sad? Why would you need medication? So it took a little bit of educating. And again, she was supportive the entire time, but I think that barrier led to, again, some shame and some guilt. Another barrier that I think is really important is the actual process of starting an SSRI. I was not prepared for the side effects of the SSRI. I had never really been on any chronic medications. So initially, within those first 3 days, I felt my jaw clenching up and I had to really look into why that was happening, and I realized it's a common side effect of being on an SSRI. The involuntary movements, my leg would kick out of nowhere, or I would be writing something down at work and my finger would flinch. And again, I realized that those were side effects of the medication. Those side effects were intense, to say the least. So I think that having, that access to being able to make those adjustments on the pharmacological side were really helpful, as far as the treatment goes.
So many important points and pearls of wisdom from you all. Thank you. Before we conclude our program, I would like to prompt our audience to pause the video for a moment and think of and write down what was most powerful to you while listening to these journeys of the patients, of the clinicians, and why. So, a few key points that I'd like to call out, and then have our other panelists also help call out anything else. We've talked about perinatal depression and screening and how it should be applied both during pregnancy and during the postpartum period or the entire perinatal period. A good screening tool is a tool that the clinician is going to be comfortable using, or that clinician is comfortable using within their office setting, amongst their staff, amongst their support. So make sure you and or your office staff are comfortable using at least one questionnaire that we've mentioned today. The EPDS has been developed specifically for this patient population, and it's a patient-reported questionnaire that's been validated in multiple languages. It's also only 10 questions. Based on the severity of symptoms, our patients need more than simply pharmacotherapy. They need combined approaches that address lifestyle factors, sleep, movement, social support, psychotherapy, and pharmacotherapy as needed. And we've heard about so many systemic barriers, cultural differences, side effects, all of which may be barriers to treatment, to access, to continuing treatment. Thank you all so much for sharing this rich, wonderful experience and conversation with us. And I'd also like to thank our audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.